very much for inviting me to come and speak. And just as I start my presentation, I'm a nurse. I'm proud to be a nurse. And I'm so excited that there has been such an emphasis on nursing in this conference. Because certainly my belief is that in Africa, well not just in Africa, but specifically in Africa, nurses are definitely at the forefront of the development of palliative care and of the strengthening of health systems within different countries. I think we still have a long way to go, but nurses are key to that. And if you want to strengthen health systems within the sub-Saharan African context, you have got to look at the role of nurses and midwives. I believe that nurses are in a unique position to be leaders in the development of palliative care, and that they have many opportunities to do that. So, as I say, I'm proud to be a nurse, but I do definitely believe in the multidisciplinary team, and we all have our unique position. But one of my key ambitions in the work that I do, both in Uganda and internationally, is to promote the role of the nurse. So I'm going to be talking specifically about our work in palliative care, and I just thought it wouldn't harm us just to have a quick reminder about the definition of palliative care, because it's about improving the quality of life of those with life-threatening and life-shortening illnesses, both adults and children. And the World Health Organization have their recognised definition of palliative care for adults. And I think one of the key things for me in this is it talks about the identification and impeccable assessment of symptoms and other issues. And for me, that word impeccable really makes me want to do a good job. They're not asking us just to do poor quality assessment. It's got to be impeccable. We have got to be able to provide the best quality palliative care we can for our patients wherever they live in the world, in whatever country they live, in whatever setting they live, and however old or otherwise they are. And as my role with the International Children's Palliative Care Network, obviously I have a keen interest in palliative care for children. And whilst in the UK here, we have done quite well in terms of palliative care for children, although I think there is still further we can go. In many parts of the world, there is no understanding of what palliative care for children is. I was doing some work in one country and I was talking to the Minister of Health, and they said, we don't need palliative care for children in our country. Children don't die. We were quickly able to show him that they did need palliative care, and whether we like to think of it or not, children unfortunately do die. So I've been asked to talk about building capacity for nurse leadership in Africa, and I think following on from our previous speaker, Africa's a big place. And so I wouldn't like to say that this is applicable for the whole of Africa. And I will be sharing specifically some of our work in the Ugandan context. But to put us into context for palliative care, again, our previous speaker was saying there is a high burden of disease. We know that there are many people with HIV/AIDS in sub-Saharan Africa, and when you look at the regions, sub-Saharan Africa is one of the worst affected. And we know that whilst this is getting better, it is still a challenge. And we still have many people who need palliative care who have HIV. With the initial advent of ARVs, palliative care was thrown out, but the need is still there. And if you look at the research, the palliative care needs of people on antiretroviral therapy is still quite high. So we know that there is a high burden of disease. Cancer is another challenge, and it's increasing. And again, from the literature, we know that this is set to increase more and more within the African context. 70% of new cases by 2020 will be in the developing world, but we don't have the health system, we don't have the infrastructure to support that. And we're not just talking about palliative care for cancer or HIV, but what about all the non-malignant diseases, all the other conditions? What about all those people who perhaps have renal failure and have no access to dialysis? What about those children who have got severe malnutrition? And yes, whilst we'd like to make sure that they could get better, they don't all get better. So the need for palliative care within Africa is great. And as I mentioned, children, nearly all child deaths occur in developing countries, and almost half of those in Africa. You know, the greatest proportion of child deaths around the world are in Africa. How are we prepared to manage that? How are we going to provide the palliative care that those children need? How are we going to provide the support to their parents, to their families? A report looking into the status of paediatric palliative care in sub-Saharan Africa noted that the humane and effective care of children receiving palliative care within sub-Saharan, children needing palliative care within sub-Saharan Africa is a public health priority. So how are we looking at that public health priority? How are we going to meet that priority? We know that there are many challenges, and I make this picture, whilst it might be quite shocking, this was the first time this lady had actually accessed care, because she lived in a community where it was the community who decided when individuals should access care. And obviously having a breast cancer like this is hidden, and so it wasn't until it was at this advanced stage that she was able to come for treatment. So late presentation, 80% of malignancies will present in an advanced stage where cure is definitely not possible anymore. There are inadequate diagnostic facilities, but also inadequate treatment facilities. There's poor availability of radiotherapy and chemotherapy, and it's great because I've been hearing about some of the links with the Uganda Cancer Institute. Up until last year, we had a cobalt radiotherapy machine in Uganda, which covered Uganda, Rwanda, Burundi, Congo, Sudan. Unfortunately, that is broken. So now we have no radiotherapy facilities at all. So how do we provide palliative care within that context? And how do we make sure that it is affordable, that it's culturally appropriate, and that it's accessible to where the individual needs it? So there are many barriers to palliative care provision, and these are just a few of them. Some of these barriers are linked to actually the individuals accessing care and what is deemed to be appropriate. But some of this is around us as health professionals. Some of these barriers are around us as health professionals not wanting to use some of the strong analgesics like morphine. And there are many fears around the use of morphine in adults and even more so in children. So within that context, how do we try and develop palliative care? What about the availability of medicines? I was horrified. My first visit to a home when I moved to Uganda in 2001, the only analgesics available was paracetamol. I was horrified. And unfortunately that is a situation, as we know, in many places. Access to analgesics, access to strong analgesics in particular, such as oral morphine, are limited. So how can we increase access to medications? How can we make health professionals aware that palliative care is not about giving up, but it's about providing life. It's about ensuring that people have the best quality life that they can have. And one of the particular barriers that I'm going to be talking about now is that around developing leaders, developing ambassadors for palliative care within the region. I have a colleague who some of you might know, Dr. Anne Merriman, and she talks about people who have fire in the belly. We need those people who have the passion for palliative care, who are prepared to go and meet with the ministers, who are prepared to go and meet with the police, meet with whoever it is, in order to increase access to palliative care. So access to palliative care around the world is quite limited. You can see the countries in red is where there is little known palliative care activity at all. And you can see that many of those countries are within the African continent. For children, it's even worse, and you look at the white colours here. Again, countries where there's little or no known palliative care for children. So we have a lot of work to do in order to develop palliative care. And as I said at the beginning, I believe that nurses are in a unique position to do this. Palliative care is often spearheaded by nurses. They have a pivotal role, and they are key to the integration of palliative care into the health system, and in doing that, in strengthening the health system. We know that there are not many nurses available. There are more nurses available than doctors. If you actually look at it, there are many more traditional healers available around the countries than there are health professionals. But we know that the availability of nurses is greater than that of doctors. But the reality is that there are very few palliative care specialist nurses across the region. As I've mentioned, there's late diagnosis and presentation, so many people coming with advanced disease. So the need for palliative care is great. We've talked about the lack of treatment options, but we also have to get a balance. I want to make sure that palliative care is available to everyone. So I don't want to make it too specialist so that it excludes access to others. So trying to develop a system where we do have specialists, where we do have nurse leaders, but where palliative care is seen as everybody's business. We did some training in Malaga, which is the National Referral Hospital, and we trained one of the senior nurses. And she said after the training, before I thought palliative care was your business, now I realise that it's all of our business. And that was really key for us, as we want to see all of the nurses within the hospital having some training and input into palliative care. But of course we have many challenges. The lack of resources, the lack of nurses. There are never enough nurses. The ward near to where our office is in Malaga, there's often 120 patients and maybe 3 nurses. How do you provide effective care within that context? What about training? What about leadership skills? And that's just one area that is really key, is a lack of leadership skills, particularly within nursing. A lack of recognition of palliative care, a lack of recognition of the training that the nurses have had within palliative care. Within the Ministry of Health structure in Uganda, there are no palliative care positions. We are hopeful that that will change in the next few months. So a recognition of palliative care within the system. So in terms of developing palliative care, we often work with this model, the WHO Foundation Measures for Palliative Care, which look at policy, drug availability, education, implementation, and now importantly research, adding research to that so that we have the information to show that what we are doing is effective. And we heard our colleague talk about the World Health Assembly, and in 2014 there was a key resolution, the first resolution from the World Health Assembly on palliative care. But what that means is that all of the member states have signed up to the integration of palliative care within their health systems. So that gives us a good way in to try and help support the development of palliative care. And if we talk about health system strengthening, these are some of the key foundation blocks to health system strengthening from the World Health Organization. You can see that, well, you might not be able to see, but at the bottom one on the left is around leadership. If we want to strengthen health systems, we have to have good leadership and we have to have good governance. So we've done some work, as I've been in Uganda since 2001. We've done lots of work with many different cadres, with different health professionals, and particularly with nurses. And in our needs assessment that we did just a few years ago, one of the key areas that nurses felt they were missing was on leadership skills. They were being put in positions where they needed to be leaders, and they didn't have those skills. So we developed a palliative care nurse leadership fellowship program. And we were delighted that this was funded through THET, through the University of Edinburgh and Makerere University. We wanted to develop nurse leaders within palliative care in Uganda, but by developing nurse leaders, we were hoping not only that we would improve the quality of life of those in palliative care, but that we would be able to strengthen the health system in different ways. And we found from previous research that by developing and strengthening palliative care in a hospital, you do in fact strengthen the whole health system. If we teach someone how to communicate well, to share bad news, they won't just be sharing bad news in a palliative care context. They can use those communication skills in other contexts. We had patients who would say, before the training, we wouldn't come to this hospital because the nurses would bark at us. Now, they are polite, they talk to us kindly. So just through developing the palliative care skills, we were able to strengthen health systems. So our palliative care nurse leadership program was in 4 parts. The first was the actual training program itself. The second was around modelling nurse leadership by specialist nurses from the UK. This was through the FET Health Partnership Scheme. And we wanted to have senior nurses come to Uganda and model what it was like to be a senior nurse, to model leadership in action. Then the third part was an expansion of a link nurse programme, and I'll talk a bit more about that in a minute. And then the fourth part was working with the Ugandan Nursing and Midwives Council to see if they can actually recognise the specialist nurses. In the Ugandan context, you have nurses, midwives, but there's no further recognition. So there's no specialist recognition or advanced nursing recognition. And so we're working with the Ugandan National Council, and as you can imagine, this is taking quite a long time, but we're hopefully going to be getting there soon, to get these nurses recognised as specialist nurses. So how did we do this? So we advertised our programme. We wanted to take 20 fellows from across Uganda. We wanted them to be working in a range of organisations, so some Ministry of Health, some NGOs, some faith-based organisations. We wanted them to be trained in palliative care, because we were not training them in palliative care. We were training them in leadership skills. And so with the exception of 2 nurses, both of whom had a degree in nursing and training in palliative care and were very key for their organisations, all of the other nurses were specialist trained in palliative care and wanted to learn about leadership. So our fellowship programme was 18 months in length. So the red blocks are taught blocks, 5-day workshops in Kampala, and then they went back to their places of work in between times, and they had mentorship from ourselves and from our mentors from the UK. They had one update day in the middle, we had a big African palliative care conference, and we had an update day around that. So we were working with them for 18 months. We covered a wide variety of areas. So the first week was around ourselves as leader, self-awareness, looking at conflict, change management, looking at what we mean by mentorship, and we used various different online tools. Some of them have been used within the Ugandan context before, some of them hadn't. Then our second talk week was more around mentorship, and then we were going to have each of the nurses involved in national level leadership projects. And so we wanted to work with them around some of the issues for that. And then the third week was the broader aspects of leadership. How do you influence the national agenda? How do you influence the international agenda? What about engaging others? Coaching? What about succession planning? What about building capacity? So as you can see, it was quite a broad programme. In the first week, we got them to develop their own individual leadership plans. We sat down with each one of them, and they were to develop their own plan in terms of how they were going to develop their own leadership skills, but also they were supposed to undertake a leadership project at their hospitals. And each of them, their senior managers had signed up for them to do the programme, so they knew that this was coming. So we asked them to look at different aspects that needed strengthening in their hospitals. So one of them said, well, we have no handover. The nurses just go off shift and the next nurses come on. There's no handover. So they developed a handover system in their hospital and were then able to show how that improved the care. And not only did they have handover in palliative care, but they had handover throughout the hospital. Another one of our nurses said, our administrator, he's not very supportive. In fact, every time I see him, I put my phone up to my head and pretend to be on the phone so I don't have to talk to him. So we worked with her as to how she could manage that conflict management. She was able to talk to him, and he is now so supportive for palliative care. It has changed the working environment. So working with her individually, providing that mentorship to help her to manage conflict. One of the examples of the work that some of them did was our Link Nurse programme. So we did a needs assessment in Malabo Hospital. We found that nearly 50% of all patients on a given day had palliative care needs in the hospital. As a specialist palliative care team, we couldn't manage all of that. And so we wanted to train Link nurses in each of the wards on palliative care, so that they could then see the majority of the patients, and then just when they had complex needs that couldn't be managed, would they bring in the specialist palliative care team. So we did this in Malabo Hospital, we evaluated it, it's been published. We then wanted to extend it to other hospitals in Uganda. And so some of the nurses, the nurse leaders, decided to implement this Link Nurse programme in their settings. How it worked varied according to their setting, but it was a good example, again, of how they were able to share their knowledge on palliative care, how they were able to get other people within their hospitals, within their health centres, really on board in terms of palliative care. And then the second part of the programme, they had to do national level projects. These were supposed to be projects that they were working together on that were important for the Ministry of Health. One of the things that we have in Uganda is nurse prescribing of morphine and other analgesics in palliative care, but it had never been fully evaluated. So that was one of the, or several of the national level projects. We got them into groups. They had to learn how to work with others in a team from other parts of the country, but making sure that everyone was involved. They had to learn about research, about data collection, about, one of them said, I've never been in a position where I had to go and speak to a hospital director before. How do you do that? How do you introduce yourself? How do you make sure that you make a good impression? So these national level projects were all developed in line with what the Ministry of Health wanted, but in particular to help develop some of these leadership skills. So I'll give you an example. We wanted to know from evaluating nurse prescribing, are the nurses doing it well? What are the outcomes of care? Are they managing to manage people's pain? And what are the challenges? So this was a big project. We had data collection. We had 20 nurses who all collected information on 20 patients. So that's about 440 potential patient information that we might have. So we had a demographic questionnaire. We then had a self-administered questionnaire asking them how they would manage pain. We then compared that with what they actually did, and they all completed documentation, as I said, on 20 nurses, hopefully on 3 different time points. We also used an outcome measure that we've developed for palliative care within the African context, and then we had semi-structured interviews. So this was a big bit of work that they were doing, and we're just now writing this up. And we've been able to show through this work that nurses are able to assess and manage pain, that they give appropriate medications, and that they know when they've reached the limit of their expertise and need to refer on. So that was a national level project, and it was really important for us that we had nurses evaluating nursing. We're trying to raise the profile of nurses. We didn't want, and apologies to doctors here, but we didn't want the doctors evaluating the nurses. The other thing was, should we be comparing doctors prescribing with nurses prescribing? No, I'm not interested as to whether nurses can do it better than, worse than doctors, or who can do it better. What I'm interested in is, can they manage pain in these individuals who need their pain managed? So that was a big bit of work for us. Then the third aspect was mentorship, and I think this is very important here in this forum. We had mentors coming out from different palliative care programs, different hospices, coming out for 2 weeks at a time, or 3 weeks, doing remote mentoring via Skype, and really linking in and trying to help support and develop the nurse leaders. So just some of the examples from the UK mentors, they've seen how palliative care can strengthen the health system, that it was a fantastic opportunity, they've learned to grow, and one of the exciting things is that at least 3 of the organisations have now got ongoing links and are now paying for their staff to come back to Uganda and continue that mentorship link. So another area that was important for us in our in the whole leadership programme was dissemination. We were helping the nurses to write abstracts and submit for conferences, then to develop posters if they had it for a poster presentation and an oral presentation, and really getting them behind owning that work. So we've had been able to present this work in various different settings, and we were very excited. You can just see some of us at the bottom here at the recent European Association of Palliative Care meeting. We were given the EAPC Leadership Award for our leadership development of nurses in Uganda. So just before I close, just want to tell you briefly about 2 of our nurses. This is Vicky. She works up in the north in Adjumani, and she is doing amazing work with all of the Sudanese refugees. and she's the nurse who had the problem with the administrator. But since doing this course, her work with refugees in palliative care has been recognised, both nationally, and she's been invited to talk about it nationally, but she was also invited to go to Salzburg and talk about providing palliative care in a refugee population. She'd never left Uganda, so getting her to Salzburg was quite fun. But it has really empowered her and enabled her, and through the recognition at the national and international level, that's helped her to get further into the refugee system. And so that's one example of how this nurse leadership programme has empowered her. Edith is another. Now, Edith works in Bombo Military Hospital, but she wasn't part of the army. And one of her challenges was that in order to be able to make more inroads in palliative care within the army, she really ought to be an officer. So she started our programme, and then she signed up for officer training, went off and did her officer training. She's now back. She's now being promoted again within the UPDF. But one of the exciting things for us was that she was able to talk about the different types of leadership. She said, when you're in the army, your commanding officer says run, and you run, and you don't think about it. But when you're working in a healthcare setting, then your leadership skills need to be different. And we've got her on video talking about this experience, and it was so exciting for her to be able to share about what she'd learned about different leadership skills. So this was our first cohort, 20 nurses. I think we finished 6 months ago. 12 of them have since been promoted, and we're having a refresher with them in a few weeks' time back in Uganda. So we've been excited by this nurse leadership programme, and we feel that not only are we building capacity for palliative care, but we are helping to strengthen the health system. We believe that with appropriate training, nurses can fulfil leadership roles, and we've seen them fulfil those roles. We also believe that the mentorship and supervision from the teams here in the UK was vital and was an important aspect of the work, and that the impact on the mentors has been great. But I think we also believe that short-term mentorship works really well within a longer-term partnership when there's clear guidelines for what you do when you go to Uganda or whichever other country. So in conclusion, in order to strengthen health systems through palliative care, it is essential that we build the capacity of nurses at every level. Training needs to be provided, and we've had discussions around should this be a multidisciplinary leadership programme, should it be just for nurses? And the nurses really value the fact that we put this programme together for them, and that it was led by a nurse for nurses. But we believe that training needs to be provided across all levels of the healthcare system. And as I said, that short-term mentorship is effective. We believe that by building the capacity of nurses, we can strengthen health systems within the region so that people like Dowdy here can have access to good quality palliative care. Thank you.